I would imagine. Okay, we are recording. Let us begin. Our Kahoot. I did this quickly while trying to handle my children, so hopefully these are all correct. Okay, which of the following could cause lithium levels to rise in a bipolar patient? Maybe if they're dehydrated, perhaps if they eat a whole bag of salty potato chips, polydipsia, starting treatment with amlodipine. Which of these could cause lithium levels to rise? Oh, I'm sorry. I don't know if there's a way to make that any bigger. Like, why do they need that whole middle thing right there? Like, I don't have a picture. Just get rid of it. All right, so about half you guys got the correct answer. Okay, so why would dehydration cause you to have your lithium levels increase? Yeah, so you're going to be in a state where you are trying to hold on to salt and water, right? And so we mentioned lithium looks a lot like what to the body and the kidneys? Like sodium, right? So you want to hold on to as much of that as you can, and so it's going to hold on to lithium as well. And so that is one thing that can lead to increased levels. So imagine being in Florida, it's going to be summertime soon, it's going to be hot. People are not maybe hydrating like they should, and those levels can definitely go up. Why wouldn't it not be amlodipine treatment? What antihypertensive could cause this to rise? A thiazide diuretic absolutely could do that, right? So again, if you're putting any kind of diuretic, would cause your kidneys to try to hold on to more salt because again, you're losing a bunch. So that could be one thing. What else? What other antihypertensives could do it? It's a loop diuretic, certainly. What else? Yeah, ACE inhibitors, right? Your ACE inhibitors and your ARBs can do that because again, those are going to be kind of decreasing that filtration that's occurring in the glomerulus, and that's going to cause you to hold on to more lithium. So that's another, again, and that's could be an important concern because again, a lot of these meds might be putting these patients on can lead to increased blood pressure, so you may need to worry about what type of antihypertensive you're going to start them on. So think about that. Why wouldn't it be the whole bag of potato chips? So you have a big salt load, and your kids are going to want to get rid of the salt. So if anything, that would drive your levels down lower, right? So that would not be correct. And then the polydipsia, similarly, if I have a lot of water coming in, if anything, that should cause initially like a dilutional sort of effect on the level, but then also as you start to excrete more of that water, some salt's going to go with that, some lithium's going to go with it too. So those are all be cases where levels should be decreasing and not rising. That makes sense? All right. Off to a good start. Who would be contraindicated from receiving frovatriptan? Someone who has their hypertension controlled HCTZ, history of ischemic stroke, psoriasis, or ergot use last week. All right, fantastic. So yeah, so history of ischemic stroke, because why would that be a contraindication? Yeah, because it should be causing vasoconstriction, so it would put them at risk for developing another, TIA or CVD or something like that. So you want to be careful from that standpoint. So CVA is what I should say. So again, that would be a contraindication. Probably want to avoid that. Try to use other medications. And again, ergots would have very similar contraindications from this standpoint. So wouldn't want to do that. Why would it not be the hypertension controlled HCTZ? So they can tolerate that additional vasoconstriction. Again, it's fairly mild. But what you're going to find is uncontrolled hypertension would be one that would be contraindicated, right? So if their blood pressure sits at 180 over 100, that's not a good patient to receive something like a vasoconstrictor like frovatriptan, right? So that would not be a good one. Ergot use last week. What's the time frame I shouldn't use these two together? And more like 24 hours. So if it was last week, they're totally fine to receive it again, right? So 24 hours is really the big thing to be concerned with there. And then psoriasis, I just needed a fourth answer, so that would not be correct.
So for the hypertension, with argot, that one is definitely a contraindication. So even if it's controlled, would that still be okay with that?
I would probably take it on a case-by-case basis, but I would be probably okay. I would probably try to err on the side of using a triptan if I can for a patient like that, but if they only really responded to DHE, they knew that, and their blood pressure was like really well controlled, they're not like on 4 meds for it, I would probably feel okay doing it. Yeah, so again, relative contraindication in those kind of situations. All right, fantastic. Teratogen's taken over. All right, a patient with ADHD and substance abuse issues would benefit most from which of the following? Try to do a pretty even distribution of the questions on this, and I tried to do that on the test as well, so it should be roughly 1/3 for each. Interesting, pretty even split here. Okay, so what am I trying to get at with this question? Yeah, you want to try to avoid controlled substances for this type of patients, right? So they already know they have a history of substance abuse. You don't want to, put them in that kind of a tempting situation. So you could utilize something as non-controlled substance. So in this case, bupropion would not be appropriate because doesn't really treat ADHD, right? You wouldn't think of that as kind of a go-to drug for that. It's more for depression, right? Dexmethylphenidate and the mixed amphetamine salts are both amphetamine-based products. They are both C2s. Those are probably not good options for that patient. However, I could use something like atomoxetine or Strattera. That's a non-controlled substance. Remember how that one works? Purely just a selective norepinephrine reuptake inhibitor, right? So it doesn't really have any serotonin effects, which is why we don't really use it for depression, but you can use it for ADHD, and some people will have a good response to that, right? Which one of these would be like the quickest acting for ADHD? Yeah, either of the amphetamines would be fine. Those kick in pretty much immediately, but the Strattera will take several weeks for it to really kind of have its main effects there. Okay, make sense? Okay. All right. Hopefully you're not exposed to one. I hope. You might not be doing quite as well if you had been, so who knows? Which of the following antiepileptics work by facilitating increased GABA activity? Go back to mechanisms of action here. Lamictal, dilantin, Tegretol, and luminol. Is that the name of the crime scene stuff they spray on like blood to see it in the under black light? Luminol. It is. And I'll post a link up to this, the actual Kahoot if you want to take it again later. Interesting. Okay, so why is phenytoin wrong? How does that one work? It's a sodium channel blocker, absolutely. So sodium channel blockade is the only way that phenytoin is really working to decrease seizure activity, right? Perfect. How about Lamictal? A lot of sodium channel, a little bit of glutamate activity, maybe some calcium. But, some of these kind of later ones, you get more of these kind of more vague kind of. We think it does several things, but you think lamotrigine, you still think like sodium channel blocker. How about carbamazepine? Just sodium channel blocker, so that one would not be correct. But phenobar, how's that one working? Yeah, so again, it's not substituting for GABA. It is directly helping GABA to work better, right? So again, it doesn't have it doesn't interact with that benzodiazepine site like a Ativan or something would. However, there's another site where it'll bind to. And what's interesting, if you look at like the side effect profile between like phenobarb versus like a Xanax or something, you can find that typically the barbiturates are going to have a lot more CNS depression associated with them and a lot more respiratory depression potentially. Also some hypotension you can see with that. And the way I've always kind of thought about it is like benzos help the channel to open up more quickly or more often. However, the barbiturates actually will have the channel open up for longer periods of time. So basically, will open up and will just kind of stay open, allowing all that chloride to flow in, and then it'll close again. So because of that, you see much more kind of more significant, CNS depressant and respiratory depressant effects you can see with that. Benzos by themselves, especially in oral doses, are very, very safe. You very rarely see anyone have a death due to just a single benzodiazepine overdose. In fact, one of the things I used to say when I was in fellowship was the only way you could die from a straight benzo overdose is if you got hit with the truck that was delivering them to you, right? So relatively safe. The barbiturates, on the other hand, don't have quite as nice of a safety profile, but also use them a lot less than you see with a lot of the benzodiazepines nowadays. So. Okay, so that makes sense? Okay. All right, Molly is taking over. Maybe that's why they're doing so well. Molly being, what's another name for Molly? Ecstasy, yep. MDMA, or methylene dioxymethamphetamine, is another term for that one. So again, that would be a stimulant. It would also help rein in your ADHD and help you do better on these kind of questions. Probably not, actually. Ecstasy is a little bit more of kind of like a feel-good kind of amphetamine because it has some serotonin kind of effects. That's why you see people like just kind of be all lovey on each other. And does anyone know why people that partake of ecstasy use pacifiers? So if you ever like watch videos like these raves and things like that, they have pacifiers. Yeah, it helps with grinding their teeth. Anyone know the term for that? Bruxism. Yeah, so it helps with the bruxism, so that way they don't grind their teeth when they're going to their EDM parties and things like that. Their techno raves, if you will. Pretty high touch. Anywho. All right. Patients being started on paroxetine for major depressive disorder should avoid which herbal supplement? Should be an easy one. This is like easy boards kind of question, and it'll come up like, don't mix these two together. Perfect. Yes, St. John's wort is the correct answer to that one. Why do you not want to mix those two? Risk for serotonergic toxicity, serotonin syndrome being the big concern from that standpoint. What's another big problem with St. John's wort? It's a CYP3A4 and a PGP inducer, so it'll drop levels of many, many, many drugs, right? So CYP3A4 is responsible for metabolizing like half the drugs out there, okay? So you got to be careful with those kind of interactions. And again, you have to ask the right questions and make sure the patients are telling you these things, so they might not think of it as a medication. What about like valerian root and melatonin? What issues could those have? Yeah, you can see some sedation with them, so you'd be careful like mixing with like Ativan or something like that. You could see some synergism there. What about ginkgo? Anyone have any issues with ginkgo? What do we use that for? Maybe for energy, but I see a lot for like memory utilization. Anyone have any issues? Any clinically relevant drug interactions? So one of the things I learned is you got to be careful with like warfarin or other drugs that are going to be anticoagulants because and they talk about the G herbals. So you think like ginkgo, you think ginseng, there's a couple other ones, but they will increase your propensity to bleed. And again, if you think about an older patient, what's starting to go from their mind a little bit? Their memory, right? So you talked about Alzheimer's. So using something like ginkgo makes sense in those kind of patients. You might try to use that for their memory impairment, but they mix that with their warfarin, and I've seen major head bleeds secondary to that. So you gotta be really careful mixing these herbal supplements. They are in no way completely safe from that standpoint, especially when you're mixing them with other medications. All right. Which of the following is most likely to affect the QTC interval at therapeutic doses? Don't worry, you guys have a whole nother 3 days to study for this test, including today. Lots of time. All right, this is a good learning point here. So, which of the SSRI should I be really concerned about having QT prolongation? Celexa and Lexapro, right? So citalopram and escitalopram. You can think of those two together in your mind, right? Again, therapeutically, you should not see a ton of QTC prolongation, but it is a concern, especially if you had someone who had, congenital prolonged QT or had some electrolyte disturbances. You can still see this issue come up here. You really want to think about the atypical antipsychotics as well. All of those, for the most part, can cause some degree of QT prolongation, so you have to watch out for those. And again, we can sometimes see what patients will overdose on their Seroquel, they'll overdose on their citalopram, they'll overdose on a ton of other meds that can all prolong QT, and you can see torsades develop. It's not an uncommon thing. The other one's clonazepam. Really, the benzos, for the most part, don't really have any QT prolonging effects. You don't really see a lot of cardiac conduction issues from benzos, so you don't have to worry about things like clonazepam. And then buspirone really wouldn't do this either. Buspirone's pretty mild from the side effect standpoint. Also pretty wimpy as far from a therapeutic efficacy. And what are we using buspirone for? Yeah, for anxiety, right? So if you had someone who could not tolerate an SSRI for whatever reason, they could utilize buspirone as an alternative, or potentially as an adjunct of agent if they one was not working, well enough on its own. Make sense? All right. I asked if it makes sense, and I don't hear anything, so I just assume it makes sense. But speak up if it doesn't. I can go into more detail. All right. Name this Street Fighter character for no points. I hope it shows up. Oh no, there it is. There he is. Doesn't look like a Ken. Maybe he used to be a Ken. I don't know. Wow, not a lot of Street Fighter players back in the day, huh? That was actually Blanka. Anyone know what his special power was? He could electrify his skin and shock people that came too close to him. He could also throw cannonball across the screen. It was pretty fun. Balrog was actually the boxer who originally in Japan had the name Mike Tyson, but they had to change it over here due to Mike Tyson not wanting his name to be used in a video game. So anywho, all right, so play more video games. It's enlightening. Just kidding. Prior to starting treatment with alemtuzumab or Limtrada, MS patients should be tested for which disease? Which organism? Perfect. Yes, TB. You have to watch for latent TB infections because they can activate in patients who are having these kind of really heavy-duty, immunosuppressive monoclonal antibodies. So again, be careful for TB. Testing beforehand. Strep pneumonia, that would not be a case where you want to test beforehand. Influenza, no. And then Lyme disease, I just need a red herring on there. But yes, that makes sense. Fantastic. All right, a patient misses 3 doses of her oral contraceptive. How should she get back on schedule? Should she take 1 extra pill for 3 days and continue as normal? DC the rest of the pack and start a new one on Sunday? Take 3 pills today and continue as normal? Take the whole pack at once and restart next Sunday? People do weird stuff. And you'll have these questions come up. At least I have, like, especially in the retail side of things, where be like, I missed a week. Am I okay? Like, am I good? Yeah, just take this Plan B with you. And, all right. You see the rest of the pack and start a new one on Sunday. That is correct, right? So if they miss one dose, what should they do? Yeah, take it as soon as you remember, and then you're back on track. You're good to go. If you miss 2 doses, shoot for 2 days. If you miss any more than that, the risk for failure of the contraceptives goes up high enough. You don't want to continue that. So you just DC the rest of the pack and then start again on. Yeah, honestly, it doesn't matter what day they started on. But again, why do we do Sundays typically? Theoretically, that period-free weekend. Again, I can't say for sure that works for every single person, but that's the common thought. Let's see. Take the whole pack at once and restart. That would definitely not be the correct answer. What would be a common side effect you might see with that? A lot of nausea and vomiting, and that's a big thing we see with a lot of the emergency contraceptives, and why you have to be concerned about them like vomiting, especially within an hour, and they have to make sure they retake the dose, because otherwise it will not. You have not had enough time for absorption in those cases. Now, can someone use their oral contraceptive pack, like they have like a normal, like like orthotricycline or something? Can they take multiple pills of that as a form of emergency contraception? You actually can, right? Because it's the same mechanism as you would see with like a levonorgestrel, which you see in Plan B. I don't have the dosing memorized right off the hand, but they would take like 5 or 7 days or something like that. You can look it up. But that would be an alternative if they had some concern where they could not get it to like a pharmacy to get a Plan B, or they could not have any other. If that was their only option, that is a way to do that. So just kind of keep that in the back of your mind. So. Oh, and then Professor Lack even taught me about. I didn't realize that they could use the copper IUDs as a form of emergency contraception. So I just thought that was mainly used for like kind of maintenance, but that was an interesting thing. But again, similar time frame. When do you want to use these emergency contraceptives within? Yeah, 72 hours is kind of that golden window you want to try to get with it. Obviously as early as possible, but 72 hours. Okay. Moving on. Which of the following would treat an acute anxiety attack most quickly? The fastest onset of action. Perfect. Almost perfect. So fluoxetine, how long would that take? Like 4 to 6 weeks, right? How long would venlafaxine take? Like 4 to 6 weeks, right? Buspirone, several weeks, right? The only thing that really is going to be good for those kind of acute sort of panic attacks, acute anxiety, are going to be things like benzodiazepines. They're good for that, right? So alprazolam, you could use lorazepam, midazolam, whatever you want. Those all would work just fine. They'll have a pretty fast onset of action. They don't take weeks to work necessarily. Because again, think mechanistically, these are getting directly up there and affecting GABA channels directly to help them to work more quickly. So that makes sense how they'd be effective pretty fast. Okay. Which of the following meds carries the biggest risk for rash and Stevens-Johnson syndrome out of the list here? So we have levetiracetam, trazodone, fluoxetine, and phenytoin. Because normally when you think Stevens-Johnson, you think rash. What do you think? Desquamation? Desquamation? What drug do you think? Normally think anti-epileptics. You think a lot of rashes and things like that. You think Lamictal is a big one, right? That's a big patient education point. You let them know about rash. But there are other drugs that will do this as well. So this is what we're trying to get at here. And we're having a whole section on this in the slides you can go back into and review. Phenytoin's a big one, right? So phenytoin, you want to watch out for the rashes. It can progress to Stevens-Johnson. You think more like lamotrigine is kind of being that kind of classic one from an anti-epileptic standpoint, but you still need to be concerned with like Tegretol, with Dilantin. Like these are all still ones that can occur. Trazodone, a lot of the antidepressant drugs, like you don't really think of that being a big concern, so not really one we think of clinically. And Keppra is actually very, very safe for the most part, really low risk of that occurring with this drug. And so a lot of patients, again, are being switched over to Keppra because it is so well tolerated for the most part, really few cognitive impairments. And if you had to think of one major side effect or kind of unique thing with Keppra, what would you think? Yeah, increase, kind of mood changes, it can increase aggression, some of the things you might see with that drug. But again, clinically, very rare that we run across that. So again, I see a lot of neurologists switching over to trying to use this as their first line drug, because you miss a lot of like drug induction you see with like phenytoin. You miss a lot of things like what would I monitor for, like Tegretol or carbamazepine. SIADH, right? So the sodium I would monitor for, things like that. Keppra is like, you can give like water and it's pretty much fine. Patients do very, very well with that drug. So. Okay, moving on. Which of the following should be avoided in patients taking phenelzine or Nardil? And I'll ask you why I put this picture up here after we answer. Fava beans with a nice Chianti. Yeah, I'm not gonna do the lip thing he does. Who was that? Hannibal Lecter. That was Dr. Hannibal Lecter from Silence of the Lambs, right? So he actually had a very high tyramine containing diet. Not only was he eating people in general, but he had with a nice fava bean and a nice Chianti that he was having with that, both of which have high tyramine in them. However, lots of other foods you can have that do not have high amounts of tyramine include like white wine. So you would want to avoid like those kind of dark reds, like port, sherry, things like that. Roasted turkey is fine. What kind of meat would you want to avoid?
Organ meat.
Yeah, potentially organ meat, but like things that are more like dried, aged, cured, things like that tend to increase the tyramine content there. And like fish is generally pretty safe to go for the most part. But yeah, fava beans is actually one of those things that is high in content. So again, I wouldn't expect you to memorize that entire list, but kind of have the broad overview of those things. And again, what can you do when you have a patient who might prescribe an MAO to? Look it up, right? So you can find this list online everywhere. You can have a printout for them so that way they can take it home. Just similar to if you prescribe someone warfarin, what would you counsel them about from a food standpoint? Yeah, vitamin K containing foods like leafy greens. Like you don't know every single leafy green out there or food high in vitamin K, but you can print something out that'll kind of help them with that, right? So, all right, moving on. That was another list of, or another movie on the list of things I was watching, bored, rocking my infant on a yoga ball for hours on end. I was like, oh, this will be not depressing. She won't remember it. It's fine. Okay. Which of the following products would be contraindicated in a woman with an intact uterus? So just the drug by itself, plain. Yes, ethanol estradiol, and that's not a polite question to ask on a first date, just FYI. So raloxifene would be okay to give for those patients. Why is that? What am I trying to get at with this question? Why is ethanol estradiol contraindicated? Yeah, you worry about endometrial tissue being stimulated by estrogen, right? And that would be a risk for. Yes, cancer, endometrial cancer is the thing you worry about. So that's why we do not give estrogen products alone in a patient who still has an intact uterus, right? However, we could use something like raloxifene because how is that not interacting here? Yeah, it acts as an antagonist in that uterine tissue, so that one you can utilize there, but it still acts as an agonist in other places like the bone. It's an antagonist in the breast tissue, so that one's okay. That you can utilize that for those patients. Medroxyprogesterone, is that okay? Yeah, totally fine. You can use a progesterone by itself. That's no problem, and we do so quite frequently. And spironolactone, yeah, again, another kind of a red herring kind of answer there. So, ethanol estradiol, do not want to use for those patients. Now, if they, are using like hormone replacement therapy, they don't have a uterus anymore, you can definitely utilize estrogen by itself. That's fine. You still have to worry about things like breast cancer risk and whatnot, but the endometrial tissue hyperplasia and cancer risk you wouldn't have to worry about. Okay. Which agent is the best treatment option for pregnancy-related hypertension? Interesting, interesting. Okay, so which ones of these are absolutely contraindicated? ACE inhibitors. Okay, so ramipril's out. What else? What else is affecting angiotensin 2? ARBs. You cannot use ARBs in these patients either. That is the same category X sort of indication or categorization there as the ACE inhibitors. You cannot use either of those in pregnant patients. You just cause teratogenesis. Good job. Okay. Don't do this in those patients. Why wouldn't Lasix be good? Yeah, it's not a really good antihypertensive, right? Because of the diuretic braking effect that happens there, the kidneys try to compensate. So you may get some transient effects, but it's not good for more long-term use. However, methyl-dopa used to be the drug choice for a good long period of time. Nowadays, we use other drugs. For instance, what can we use? Go back and look at it. Let's say you have things like labetalol is a decent option. You have things like, if someone's having like early contractions, you can also use things like nifedipine that can be good as an antihypertensive as well. So you have treatment options, but you really want to avoid things like your ACE inhibitors, your ARBs, because those are definitely known teratogens that would not be good for those little growing fetuses. Okay. Moving on. Uh-oh, Molly got taken over. Who feels like they need antidepressants after taking this class? Decisions. Only 15 of you got that one right. This class is about levity, about raising your spirits, not dropping them down even lower. That's what test day is for. Come on, guys. Just kidding. What's a Baker Act? Everyone know what that is? What is that? It's like an involuntary cycle, 3 days. Is it 3 days from the time you actually Baker Act them? Yeah, so once they've been medically cleared, so you have to have, they're like, intubated for, in the ICU for a week or two. Like the clock doesn't actually start until they're medically clear. So, all right, cool. Who can Baker Act? Doctors. Actually, I don't know the laws strictly on PAs, but the other non-healthcare providers that can do it. Certainly psychiatrists can do it. Police officers can do it. You might see police officers initiate a Baker Act, right? Because again, oftentimes when you have calls like that, who are the first people to respond? Yeah, usually the cops are going to be there, right? Because again, the cops are more numerous typically. They're usually closer to a lot of these scenes, so they might be the first people to respond. Anywho. Which of the following medications would be best suited for migraine prophylaxis? No one said Percocet? Those are lame. No, okay, so again, the question here is what's going to be best for prophylaxis, not for acute treatment of a migraine. That's important to make that distinction here, like we do for lots of things, like anxiety, for instance. We have long-term management, and then we have things for acute anxiety. Propranolol is a good one. Propranolol certainly can cause migraine in certain people, but that's why you need to do things like dose it low and titrate up slowly in these patients, but it's good for prophylaxis. A lot of people do respond well to that drug. But sumatriptan, dihydroergotamine, those are only treatment for acute migraines that are actually currently happening, or if they have like an aura coming on and they know it's going to happen, they can potentially use that as a preventative in that case. Make sense? Okay. All right. The first line treatment for gestational diabetes is, this one should be pretty straightforward. We'll cover these more in the endocrine section, but we covered it enough in the lecture for you to be able to answer this, I think. Yes, dietary modification. Whoa, the drug guy went with the non-drug answer. Interesting. Yes, you should try to fix this stuff with diet first, because again, we like to limit drug exposure in pregnant patients as much as possible. Is insulin a teratogen? No, your body produces it already, so you don't have to necessarily worry about it from that standpoint. It's relatively safe. However, how do we give insulin typically? Subcutaneously, right? And so again, it's a lot of education. A lot of people are very needle phobic. They want to start injecting themselves just for the duration of this pregnancy. So you can fix it with diet. Try as best you can to fix it with diet. Glyburide and metformin could potentially be used. However, those are not going to be first line, right? So, and they don't have as much evidence for use as something like insulin does. So again, depending on who the provider is, they may choose one or the other, but really dietary modification is the first thing you want to do. Okay. Which of the following can cause a chemical abortion, but is also used to induce labor? Yeah, so misoprostol, anyone know what that is a synthetic version of? So think prostaglandin, right? So think prostaglandins. Now you can use it, especially like directly at the cervix. It'll help to increase like cervical ripening and get someone ready to induce labor in some cases. But if you used it earlier on in pregnancy, and they would sometimes mix this with like methotrexate in order to cause like a chemical abortion. So again, that would be contraindicated earlier in pregnancy than at the time of labor. Oxytocin itself, it would not be used for that case. Certainly use it at the time of delivery in order to help kind of speed things along. But again, itself would not necessarily be like an abortifacient like misoprostol is. What would nifedipine be used for? As a tocolytic, right? So it can help to kind of relax some of those kind of early contractions. You could also potentially use it, especially if they had hypertension associated with their pregnancy. That could be kind of a two birds with one stone kind of situation. And then what do we use terbutaline for? Also as a tocolytic. That works how? It's a beta-2 agonist, right? So it's a beta-2 agonist, and that's going to cause smooth muscle relaxation, namely of the uterus. So it's going to help to relax that and help deal with some of those early contractions. Okay. Which medication route is least preferred during an acute seizure? Yes, why is oral not preferred? It can be very difficult to give someone who's actively seizing because a lot of times those muscles are clenched up. And the other thing you have to worry about with someone who's seizing is what? Aspiration, yeah, so they vomit, they can aspirate. It's no good from a respiratory standpoint. So oral is not going to be preferred in those cases. However, intravascular, if you have access, is good. It's very difficult to get intravascular access on someone who's actively seizing, so that may not be the most preferred method. But if it's already there, then you can use it, especially if they're already like in the ER, inpatient, whatever. Rectal, what do we give rectally for seizures? And diazepam, right? We have the Diastat is the brand name for that as a rectal formulation. So again, if your loved one or the patient's having an active seizure, basically would have this kit all ready to go. Pull it out of the pants. Make sure they lubricate the end of that because that's one of the things that you run into. It comes with a lubrication packet. They need to use that, otherwise it can cause rectal tears and some injury there. But basically just insert it into the rectum and inject the medication. It's one of those things where they will preset the dose coming from the pharmacy to how much they should get based on their size, and then that's one quick way to manage that seizure kind of in the early phase. And then certainly intramuscular is a good route to use, especially if you don't have IV access. Okay, but intranasal could be on this list as well as a potentially useful route. So we'll use some intranasal Versed or midazolam with some regularity. So it just depends. Okay. What is the latest numbered Final Fantasy? Who's up on their Japanese RPGs?
I think it's 7.
Some people don't know. It's kind of counterintuitive that there's any more than one Final Fantasy, right? Because you think it's your final one. Wow, about half you guys knew 15 was the correct, or at least guessed that 15 was the correct answer. Fantastic. Yes, 15 is the latest one. Probably not anyone's favorite, but that's okay. It's like 7 or 9 for a lot of people. 6 is a good one. You're 7 guy? Yeah, 7's pretty good. 9, I like 10. 10's good. 6 is like God tier level though. Okay. Anywho. That's my elective I'm going to have next semester is literary critique of the Final Fantasy series. Anyway. What is the drug of choice, not Department of Corrections, for acute dystonia after taking haloperidol? So we had a patient who presented like this, acute dystonia. How would you manage that? It's very rigid. It's very uncomfortable. You need the medication to give him quick. What are you going to pick? We have olanzapine. We have flufenazine, metoclopramide, trihexyphenidyl. Trihexyphenidyl will be the correct answer with this one. Okay, so talking about this, why would olanzapine be incorrect? Still has some dopamine 2 receptor blockade, because again, what is the primary issue here? Patient received Haldol, we blocked those D2 receptors, and now he's having an acute dystonia. So we don't want to give him anything that's going to also block D2 receptors even further. So olanzapine, even though it's a second generation agent, is still going to have some D2 blocking capabilities, right? The other big thing that differentiates the mechanism of action for the atypical or second generation antipsychotics is what? There's that serotonin antagonism that happens more kind of in that frontal cortex, but they still have some D2 blockade happening there. So that would make it worse. How about flufenazine? That's another really high potency D2 blocker similar to Haldol. So again, that would also make it a lot worse. So you wouldn't want to do that. And how about metoclopramide, Reglan? Talked about it. It's an antiemetic, but actually also has D2 blockade, as we kind of mentioned briefly. We'll cover that one more so in the GI section a little bit later on in this class, but that is one you would also want to avoid. I probably mentioned that story of like these HEMONC patients who are having really bad nausea, vomiting. Metoclopramide is all they had for a long time. They developed these kind of acute dystonias potentially because they'd have such high doses on board, tardive dyskinesias in the long term, things like that. However, how do we treat these acute dystonias? What type of drug do we use? Anticholinergic, right? So we have things like trihexyphenidyl or artane. We have benztropine, which is cogentin, and then the primary one you might see most commonly is Benadryl, right? So Benadryl, diphenhydramine, being a first generation antihistamine, has pretty good anticholinergic activity, so that would be also an acceptable answer in that case. Okay. All right. Which of the following should prompt immediate discontinuation of oral contraceptives? Obviously, a positive pregnancy test would be one, but so. 1 second left. Oh. That is true. Acute chest pain. What could that be a sign of? PE, absolutely. So PE, anything like that. You know, if you had, DVT, very obvious DVT. Really painful calf, only one calf. Really painful, palpable cord, anything like that. Those are signs. DVT / other kind of thromboembolic condition. You need to get that checked out and discontinue use immediately. So educate on that. Skin hyperpigmentation. Again, it may happen. Probably not going to be immediate concern from an emergency medicine sort of standpoint. How about intermittent headaches? What type of headaches would you say, yes, you should probably discontinue use? Yeah, worst headache of your life, very severe, sudden onset headache, like that could be a sign of a stroke, right? Ischemic stroke there. And then breakthrough bleeding, kind of a common side effect. It could be a formulation issue. It could be something that, again, you want to give them a few months trial to see how they may get some degree, may get used to it at some point, may kind of regulate itself. However, you may need to switch therapy, but it does not mean you need to stop completely. Okay, moving on. Controlled studies in women fail to demonstrate risk in fetus during first trimester will be which pregnancy category? Again, I had limited space to write these questions. I randomized the answers, so that's why it comes up all goofy. I don't have dyslexia, not that I know of. Do you know what the dyslexic atheist said? I don't believe in dog. That's a bad joke. Yes, that would be category A. So the key point here is there's controlled studies in these women that showed no risk of harm. How easy is it to do these controlled studies? Nigh impossible nowadays, so we cannot do these. So very few drugs get moved up to a category A sort of thing. Now category B would be things where either there may be some animal studies that show harm, but we have lots of human data that says this is probably not a risk. And so again, it's easier probably to get into a B categorization than anything else. What would C be? We don't really know. We don't have enough evidence to really say. There may be animal studies that show risk of harm. We may not have studies yet to show, or any kind of evidence to show that there's risk for humans, so we kind of don't know. It's kind of shrugging. What would D be? D would be that there is documented harm to the fetus. However, there may be some situations where treatment of the mom would outweigh the benefits there would outweigh the risk to the child. Think about like warfarin in the case if you had like something like a mechanical heart valve, your risk of thrombosis. So that in very rare situations generally would not use. And category X would be never. Yes, bad, but you would never use it. There's no cases where benefit to the mom would outweigh the risk, so you just avoid those completely. So like your ACE inhibitors would be a category X because we have lots of other drugs we can use to treat hypertension that would not be as dangerous to the fetus. All right. What is the name of this character from Mortal Kombat? Show the picture. Show the picture. No, it didn't show the picture. Read my mind and guess which picture I would have had up here. This may say more about what you guys think of me than what I expected you guys to know. It was actually Scorpion. Good job. Yeah, that's who I would have put up there. Obviously, my Kahoot skills need some improvement. That's okay. All right. See, last question. Which of the following antiepileptics can cause pancreatitis and hepatotoxicity? Think drug-induced pancreatitis, you're thinking this drug. All right, valproic acid is the correct answer there. Yeah, so you really think hepatic issues, you think pancreatitis potentially with valproic acid. Benztropine, not an antiepileptic, so that would not be a correct answer. Ativan, don't normally think about, certainly, you think about the drugs that are good for like older patients. Like that's one of the benzos we said. Remember the acronym we used for that? For like good benzos for older patients? LOT, which is for lorazepam, oxazepam, triazolam, and temazepam are the four good ones for that. So again, that avoids a lot of hepatic issues. And then clobazam is another benzo, but not usually associated with that. So valproic acid is one of the big kind of obvious one for that standpoint. All right, let's see who our winner is. Chicken Little. Chicken Little. That's you. Good job. Fantastic. You can raise your hand up a little higher. You want to be proud of your gold star standing here. Yay. Oh. Who is player 2? You guys are colluding, perhaps? Molly? Who's Molly? Wow, on the same row. You guys like tend to do that. Like you got the like the back row. You got good job, fantastic. Okay, what questions can I answer for you regarding test material? What are the answers? Well, the winner gets one free answer. B. Any questions? Again, I will try to answer questions throughout the weekend. The test is Monday morning. Try to get your prescription assignments done as well. Otherwise, bad things will happen to your grade. You just won't have one. Yes, sir. The big ones you think SSRIs, the prolonged QT, think citalopram and escitalopram. Those are the biggest risk ones. Anything else? Okay. Well, if not, whoever hated short lunches, guess what? I'm giving you a nice long one. And I will see you guys on Monday. Actually, I won't see you on Monday. I'll be at my other job. But I will see you guys on Tuesday probably.